Good morning. My name is Michael Irvine, for those that don't know me, and I want to thank each and every one of you for coming to our event this morning. Our mission this morning that we're looking to accomplish is the following. Number one, we're going to try and help bring some clarity to one line item in your P&L, which commonly is recognized as something that's uncontrollable, called health and welfare cost. Number two, we're going to look to share with you some tools and strategies that have been historically used solely by large market employers. Number three, we want to provide you a means of playing offense in lieu of defense in negotiating your health and welfare cost. Number four, we'd like to define a process that will bring you a long-term, sustainable benefit strategy. And last but not least, demonstrate a technology platform that will help you enable you to manage and measure your results. With that, I'd like to introduce Mike Devine from MF Irvine's benefit consulting practice.
Morning, everybody. Thanks for the round of applause. I'm going to talk to you for about 10 minutes or 15, and I'd like to echo Michael's sentiments. We're very appreciative that everybody here took the time to come here this morning, understanding that everybody's very busy. I won't take more than 10, maybe 15 minutes of your time. And while my portion of the presentation probably isn't the most thrilling, I think you're going to be excited with the demonstration you'll see shortly that's going to show you how this technology works. But my goal today is to sort of lay a baseline. Like I said, everybody here has chosen to come here this morning because you understand that there is a problem. And the problem is your health care costs are rising at a rate that's absolutely unsustainable. What's probably most frustrating about that is in large part you don't quite understand why. It's very difficult to get your hands on the data that helps you understand why. And beyond that, it's that much more difficult to then put a strategy in place to try to curb that growth. So to that end, we're going to talk to you today about some of the solutions that are available, some of the tools and technologies that, as Michael said, have not been historically available to smaller and mid-size employers. So that's the goal for today. And before we get into those new technologies, those new solutions, those new strategies, I wanted to lay a little bit of a baseline and run through a year in the life of the medical plan for a lot of mid-sized employers today. So I hope this doesn't sound familiar to people, but I worry that it might. So what I've done here to help us walk through this is put together a timeline. I've made everything way too small for you to read in case there's typos or anything like that, so hopefully you won't note it. But in January, we're going to assume that's when your plan year starts. Okay? And then you're going to see a 10-month period here that's essentially a complete blackout. And that's what we find with a lot of mid-sized employers, is that for 10 months out of the year, there's no management of the claims, there's no understanding of how the claims are running. Are they trending up, down? Why is that? Is it because people are getting sicker? Is it because they're not using the plan correctly? So there's a total lack of clarity. And all of a sudden in October, CFOs kind of start to twitch a little bit, knowing that this renewal is coming their way, and they have no idea what it's going to be. Are you going to get lucky? Are you going to get a 5% increase? Are you going to get a 10%, 12%, kind of the norm? Or is it going to be one of those real bad years? It's going to be 15, 20, 25%. And that absolutely happens to a lot of employers out there. So again, the goal today is to figure out how do we understand what the data looks like throughout the course of the year. And what that's going to allow you to do is, first of all, have some concept, at least, of what your renewal is going to look like come January 1st. And more importantly, and taking the next step beyond that, it's going to help you understand what's really driving those claims. And more importantly, while it's interesting to know and understand, what can I do about it? Because that's what's going to affect your renewals and try to keep your costs down over time. Everybody goes through the renewal process. Everybody laments the fact that we're going to have to swallow a 10 or a 15 or a 20% increase. And of course, you understand the short-term pain that's associated with that. But maybe you haven't had the time to sit down and model out what does that mean to my long-term profitability over time if this continues to happen year over year. which it has for a decade now. So what I've done is put together an exhibit here that shows you what we're assuming is an employer of about 150 lives with sales of about $10 million. And it costs the company to run the company $7.65 million in non-medical expenses. So everything that's not your medical plan is costing you $7.65 million. Your medical costs is $1.35 million. So your profit that's left at the end of the day is $1 million. You're operating on a 10% profit margin. So what does that mean to me in subsequent years if I'm able to grow my top line at 5%, I'm able to keep my other expense growth to 5%, but year over year over year I'm stuck with this 10% growth in my medical costs? Well, if that's the case, it's going to take a short 12-year period before your profit is completely eroded. So on this bar graph, the blue line represents those non-medical expenses starting at the 7.65, growing at 5% a year. The red is your medical expense, and you see that's what's growing disproportionately and ultimately eating up the profit. So that little green bit at the top, that's the amount you take home at the end of the day, keeps getting smaller and smaller and smaller, and 12 years later, it's completely gone. So I know everybody in the room understands that there is a problem, but I think this clearly demonstrates the magnitude of the problem and the immediacy of the problem. I also think it's interesting to take a look at this not in terms of corporate profit, not in terms of corporate expenses, but this is your employees too. So if you're passing along that 10% increase to your employees because you're taking a 10% increase every single year, think of the green that we're calling profit for the company. Think of that as their savings. In 12 years, they can't save a dime anymore. If everything else is growing at 5%, but disproportionately, you're asking them to pay 10% more in order to keep their family covered with decent medical insurance. So we've talked about these increases, the double-digit increases that are commonplace. You know, they're not accepted, but they're commonplace and they're happening year over year over year. Why is that the case? Well, there's a lot of factors, and pretty soon I'm going to talk about underwriting and how the carriers calculate your renewals year over year over year. And I want to make it clear, I'm not up here to demonize the insurance carriers. We work with them, they're good partners to us, but they absolutely have their shortfalls. But they're working in a very challenging environment just like we are. And some of those factors would be that unit costs continue to rise. And they rise at a rate significantly higher than inflation. So if you go and you get a CAT scan today, and then you do the same thing a year from now, it's not 3% more expensive, it's 5, 8, 10% more expensive. And even more important than that, new technologies, new procedures, new treatments, new drugs are coming out onto the market all the time. And new in medical and prescription world means expensive, because a lot of people have put time, money, and effort into developing these new technologies, and so they're trying to make their money back in the first few years before everybody else can copycat them. We have an aging and an unhealthy population. I think that speaks for itself. Healthcare reform, we could get President Obama and Mr. Romney to talk about just what kind of an impact that's having on your costs. I won't get into that too much. But the bottom line is these costs keep going up, and it's not strictly that the underwriters at the carriers are trying to line their pockets. It's not necessarily that they're taking home double-digit profits every year. They are working in a very difficult environment, but there are alternatives to that. So I wanted to talk a little bit about underwriting formulas, and probably the most important aspect of underwriting formulas, particularly for mid-sized employers, is a concept called credibility. And credibility is basically the amount of weight that they're going to put on your group's specific claim experience. So the amount of claims that are generated by your employees and their dependents. That's only one aspect of how they determine what they think they're going to pay out in claim costs on your group. The other part of that is what I'm going to refer to as manual rates. And that's basically an actuarially driven factor, okay? So they're going to look at your demographics of your group, your employees, the spouses that are covered, and the children. They're going to look at the age, the gender mix. They're going to look at how rich your plan design is. They're going to look at where your people are located, because of course the cost to deliver health care is different across the country. And they're going to come up with a number that way. So I've put two exhibits up here. Company A has a relatively healthy population. On average, their per employee per month claim cost is $800. But there are only about 150 lives on this plan. And because it's not that big, the insurance carrier doesn't necessarily believe that this $800 per employee per month claim cost is what they would call credible. So that claim cost is only going to be weighted at 30%. The other 70% is their book of business, which says, based on the demographics, based on how rich the plan design is, that claims are actually going to be $1,000 per employee per month. So if you take a look at this, only $240 of your good claim experience, if you will, goes into figuring out how much claims they think they're going to need to pay as they develop your premium. The other portion, $700, comes from that manual rate, their book of business rate. So in the end, Company A, that has a healthy population, has an expected claim cost of $940. They're overpaying on their own specific claims by 18%. And that's the baseline that the carrier uses to then build the rest of your premium, with the premium tax, risk margin, the profit, their administrative expenses, all the other things that go into your claim dollar, your premium dollar, excuse me, and Paul's going to talk about that a little bit more. Now, I said I wasn't up here to demonize the insurance companies, and I'll prove it. Company B is the unhealthy population. They're generating $1,200 worth of claims. If you run through the exact same calculation, see the manual rate's going to be the same, their expected claim cost will only be $1,060. So the bottom line here is healthy Company A is subsidizing unhealthy Company B. And the question for everybody in the room is, do you know if you're Company A or Company B? If the answer is no, the demonstration we have for you today is going to show you that you can. And not only can you know whether you're Company A or Company B, you can take positive steps to affect a better outcome. If you're Company A, to stay Company A. Keep your employees healthy. The few that are unhealthy, move them toward healthy behaviors. Company B, on the other hand, you can figure out why your claim costs are higher than book of business average and what you can do to bring them down in line. Now, once you've done that, you still have this problem with the underwriting factors. Say you move from Company B to Company A. You're still not getting credit for everything you've done now that you understand who's sick and why are they sick, how can I help them get better, and now I've gotten to the point where my claims are lower. We've got a solution for you there too, and it involves a little bit of an alternative funding arrangement. Paul Miller is going to talk about that in just a little bit, and I don't want to steal his thunder. So today with us is WellNet, and I'd like to introduce Keith Lemmer, who's the president of WellNet. They're a great partner of MF Irvine's and have been for several years. The goal of that company is to help everybody in this room gain control of their claim data, understand what's driving it, and outreach and proactively manage the healthcare spend in your plan today. They have great tools, access to great data, and they actually go out, they do the outreach in conjunction with your HR department, in conjunction with MF Irvine, and they can help turn around the costs that we're seeing growing at 10% year over year.
Everybody mind if I walk around a little bit? Can you still see me down here? Terrific. Thank you, Michael and Michael Irvine, for having me today. My name is Keith Lemmer, and I'm the president of WellNet Healthcare. I'm joined by Harry Kovar, who's the chairman and CEO and founder, along with John Augustine, our East Coast representative. And we really appreciate you all being here today, giving up an hour or so of your time to learn about really tools and technologies to control and manage healthcare expenses. Now, rather than just get up here and talk the whole time, I'm curious to see, by a show of hands, is anybody able to fix a problem if you can't recognize what it is first? Right. I see very few. I don't see any hands up here. Duke Mercer is here from Euro Motor Cars out of Bethesda, Maryland, and Chester, Pennsylvania as well. And Duke, I have a question for you, which is, how do you all keep track of how many cars you all sell on a monthly and on an annual basis?
We keep track of the sales and the inventory so we can manage the process for our profitability.
And so you have that data, you have that technology that allows you to do that, right?
Absolutely.
And so if a car is not selling, you know whether to possibly reprice it or move it off the lot?
Absolutely.
So
Evaluate the change.
evaluate the change. So in essence, recognizing a problem, making a change, ultimately measuring it, and then doing it on a continuous basis. Can anybody in this room do that with their healthcare plan? Yeah, I see a lot of heads shaking. Yeah. You turn to the next slide. Thanks. What I'm going to talk about today with my partners is really an understanding of how, if you have information, you can understand what's driving the cost of your healthcare plan. You can understand what the issues are. You can understand how to manage the health plan. You can understand how issues are going to affect your company long term, from predictive modeling, where the costs, where the risks are going to be later on. But if you don't have data, if you don't have information, you can't do anything about it. Shopping, spreadsheeting, year after year, is that working? No. Obamacare, suspect at best. We understand from what we've seen, costs are continuing to rise. And so we like to tell a story with an infographic, pictures that tell a very complicated story in a simplified manner. You've got 3 bridges here. The bottom bridge, it could be Cigna, it could be Blue Cross, it could be Coventry, you name it. The large insurance companies, the ones that are out there primarily protecting their profits, they do a very good job in providing access, paying claims, moving a few levers for plan designs, ultimately getting many employers to think that they're actually saving them money when in fact, at the end of the plan year, the plan has gone up another 5 to 15 or 25%. In addition, you may all hear about disease management, wellness programs. Many of the carriers have them, but they typically add them on as an afterthought. And so the results in terms of how many people are engaged are suspect at best. Ultimately, a lot of money is going out the door. Then you have disease management companies, wellness organizations, those that are actually out there, independent solutions, engaging members. Some of them do a very good job, but they're only as good as the data they get, the information they get. And if they don't get data, if they don't get it in real time, it's very difficult to actually do something about it to lower those expenses. And so what our company has done, WellNet at the top, is we've taken best of breed partners, the best networks like Aetna and Cigna, the best pharmacy manager like CVS Caremark, our own nurses in-house using technology that we've built from the ground up to give our customers, our partners like MF Irvine and their customers, the ability to actually see what's driving the cost, as I mentioned, where are the problems, what can I do about it, how do I engage people, and how do I measure it, how do I do it all on a continuous basis, exactly the same way that Duke is managing his inventory. So what we've done is built a solution that bridges the gap, gives you all the control that you need, the insight and the understanding. Next slide. And it's all about one thing. It's all about getting to the root of the problem. If you can get to the root of the problem, you can fix what's broken. But if you don't have that claim data, if you don't have that understanding, if you don't have that insight, it's very difficult to fix those plans. So just taking a step back for a moment, we were founded in 1994 as what's called a standalone pharmacy benefit manager, providing prescription drugs, our prescribed division, groups under about 5,000, carving them out from the plans. And the reason we are still in that business and have been in that business is that the pharmacy data is the best predictor of information in terms of telling us today what's wrong with the plan tomorrow. So we migrated and became a population management firm. Nurses on staff that actually outreach and engage members, nurses that actually keep members healthy, that show actual measurable savings, and that actually take that data from an advisory perspective and engage the members in real time, giving the customers the insight and the understanding they need. So if you take those three components and you say, wait a minute, how do I really affect the 80% of my claim costs that I'm not seeing reduced, the medical benefit? What we've done over the past 24 months is partner with Aetna and with Cigna to, in essence, build a plan that looks and smells exactly like the offerings that you all have from Blue Cross, from the other carriers, even if you're self-funded already, and built a plan that has the best network discounts, pharmacy benefits, medical benefits, technology, and population management, along with stop loss. So all those programs, all those plans that actually give you the tools and the understanding that you would like but don't currently receive from the carriers out there today. And how is it all woven together? It's woven together, as Michael had mentioned before, both Michael Devine and Michael Irvine, with our WellNet 4.0 technology. If you have technology, you can actually have the information at your desktop. You can actually see what's driving the cost. You can see where the risks are. You can see what kind of changes you need to make to the plan. You can outreach and do campaigns all on a turnkey basis. And that's what we've created, our best of breed solutions that allow businesses the control and the understanding of how to manage, measure, and engage their plan for the purpose of one thing, to save money. And it's all, as I mentioned before, to get to the root of the problem. Next slide. Some of the groups that are using us, public, private, nonprofit, here in the area, organizations such as A. Dewey Pyle, along with Burpee Garden Products. It makes no difference whether the group is 50 employees, 500 employees, 2,500 employees, or even groups like Penske Automotive that are in the same space as Euro Motor Cars. These organizations have been with the Blues, have been with Cigna, have been with other administrators, and they've had enough. They can't see the insight. They don't have the transparency. So they've selected WellNet to manage their benefits, to give them the understanding. And even taking a group like Dollar Financial, an MF Irvine client, before we came in, they had no claim data that told them that 18% of their population was driving 55, almost 60% of their costs. We're now able to get their plan under control, give them the tools, the understanding, and the insight to strengthen their roots and to drive down their expenses. So a closer look on the approach. So if you think about it, if I could take data and have it interpreted and have access to it and have understanding, I have the ability to control. But if I don't, I have no ability, I have no understanding and no insight. We've built something, we've spent about 4 years developing a technology called WellNet 4.0. Not only does WellNet use it for our customers, like Dollar Financial, but also the federal government, as well as for some of the exchange business. We license it out because it's the only type of technology that's out there that takes lots of data from all over the place, brings it together in a dashboard, allows you to automate processes. If I want to reach a member that has a brand name medication that should be taking a generic, and I have a population of 300, let me push out a message to them. Let me incentivize them. Let me measure it. Let me manage it. And if something's not working, let me do it again. Imagine if I have a company and I've got 3 different eligibility files. I'm unable to figure that out if I don't have that data. So we're bringing data together. We're bringing automation, communication, and connectivity. If you have automation, you have integration, and you have connectivity, you finally have control. And what we're going to do in a few moments, led by John Augustine, is go through some of this technology that shows you exactly how, whether you're 50 employees, 500 employees, or 5,000, to actually have all of your claim data, no names associated with it, no identifiers, but your population in terms of the risks, the cost, and what can I do about it, all on your desktop, and the ability to engage members, whether it's at their computer, their wireless device, texting, the ability to actually use Web 2.0 technologies to drive down those healthcare costs. John. So what does the technology do? And I'm just going to hand it over to John in just a moment. If I have a population of 100 people, it's very difficult for me to see where those costs and those risks are. So on the front end, if we could take the data whether it's pharmacy or medical data, and do risk profiling to understand where the costs and the risks are. In essence, what cars are selling better than others, what population is unhealthy versus healthy, and then how to actually outreach and engage them. We can target the specific conditions and measure it on a continuous basis. And the key for anybody in this room, what's the ROI? What is my actual savings? And if you bring those 4 items together, you have an end-to-end solution that finally puts companies and groups like MF Irvine back in the driver's seat. I'm going to turn it over to John Augustine, who's going to go through a couple of modules. In essence, what does a customer who's 50 employees or 500 employees see on a regular basis in terms of their data, their understanding, and their ability to manage and measure on a regular basis? John.
Thank you, Keith. So as Keith alluded to, wellness technology is very exciting. It provides transparency into really all of the cost drivers within your plans. In essence, we've built an ecosystem for healthcare. We've built portals that touch every single stakeholder, from the administrator of plans to the decision maker within an organization, all the way down to the member and to the nurses that manage those members. So we've got a portal for every single stakeholder that touches that healthcare plan. And when you create that type of collaborative environment, it allows all the smart people involved to make more poignant decisions and ultimately reduce your healthcare spend. MF Irvine also has their own portal. In essence, I'm going to show you 3 of those portals today, because I could spend 2 hours showing you all the cool functionality of this, but we're going to hit on the top things today. So this first portal we'll talk about is called Active Reporting. This is the same portal that MF Irvine has access to. So for every single group that they engage WellNet on, and for every client that they have that's with WellNet, they get to see a view of your data, in essence, all in real time. So everything you'll see today is in real time. We're going to look at just basically this performance section today. And we can share things with you like your total medical claims, all in real time again, all your pharmacy claims. And again, this is aggregate data. Rather than go into this, I'm going to really go into the things that really drive the ability to manage risk. So these are your drug reports. Historically, companies have used this type of data, as Keith alluded to better understand what's happening within your population. If we know that a member is taking 5 medications, statistically we can glean from that information exactly what's wrong with the member on the medical side. That's effectively why pharmacy information is so useful. Now, everything we'll show you today, our technology is synced in real time with Johns Hopkins. So when we've got the data in our system and we can share it with Johns Hopkins in a secure environment, it allows us to benchmark, it allows us to predict the future. Because Johns Hopkins has seen that 50-year-old male that's taking 5 medications, and they know statistically exactly how much in healthcare costs that guy will cost next year. They've seen so many claims. And that's really the beauty of partnering with a company like Johns Hopkins. So this drug data, very important. These are your top 5 drugs by cost to the plan or by number of users. If you'd like to sort this data, you actually have the ability to do that all in real time, and within a few seconds those dashboards update. You have the ability to double click on any of our dashboards and you'll actually get a full-on view of the information. In this case, a full-on drug report, which you can then sort again by condition if you'd like, or by top 10, 25, or 50 drugs. Again, when you have this data, you can see what people are taking, if it's brand, if it's generic, what it's treating, how many people are taking it, all the way over to what these drugs are costing you, what they're costing your members, and whether they're utilizing these things from a generic perspective the way they ought to be. You can hit export, save it, print it, cut, slice the data any which way you'd like. Now here comes the risk management stuff. WellNet manages risk in really 2 ways. And I'll talk about stage 1 risk management and stage 2 risk management. Keith mentioned that WellNet has a team of nurses, and we do. And those nurses are very good at engaging the right people at the right time. And it's because we've got the information necessary to do that. So this is our predictive modeler. And again, it's based on the Johns Hopkins modeler. When I double click on any dashboard, it gets bigger. Then I can maximize things by clicking these buttons here. And I've already done that. So there's a lot of data on the screen. I'm going to take you through the most critical items. So this employer group has 2,100 employees. When you add dependents and spouses, we're talking about 4,400 total members. Now, Johns Hopkins has tens of millions of claims in their data warehouse. So when we share your group's claims information with them and the demographics, Johns Hopkins says, look, statistically, there's 119 people. Sorry about that. There's 119 people at high risk. And Johns Hopkins goes one step further and says next year, on average, every single one of those members will incur about $37,000 in claims, statistically. We know what drugs they're on, we know what medical claims they're incurring, and statistically, over all of our years of collecting data, we know that these members will average $37,000 in claims. Furthermore, there's 808 people in this population that next year will average 4,400 in claims. Now, what does all this mean? Next year, Johns Hopkins is telling this group of 4,400 members that they're going to, very likely, incur $9.5 million of claims. But when you look a little bit closer, over $8 million of those claims are coming from only 21% of the population. And that's stage one of our risk management. Our nurses know exactly who these members are. You don't need to know, nor can you know, but we do, and that's why you engage a company like a WellNet and an MF Irvine. We've both been good at managing risk, and WellNet's nurses take these 927 people and put them in order, from most risky to least risky, and that's where we begin our outreach. Initially, it's telephonic, but we've got web outreach, which you'll see in a moment, all the way down to a mobile phone. So members, which I'll talk more about, can access all of their claims data in real time with a couple taps on their Android or iPhone, which is pretty radical. So stage one of our risk management is the identification of the high and medium risk folks, and then a collaborative effort between you, MF Irvine, and us to figure out the most effective ways to engage those members. Every population's different. We've certainly got our best practices, but we do need your help to better understand your populations. Now, as Keith alluded to, the carriers, and in the fully insured world, everyone tells you, well, we've got that. We've got nurses. We've got predictive modeling. We do outreach. But the reality is, when's the last time they actually showed you a success? So WellNet's built a dashboard here that actually shows you feedback on our care management program. When our nurses are engaging members, we're using a nurse portal to track every communication, everything we ever do with your members. And when we log all of those things, they end up on this dashboard. So you get to see how many people we've identified so far, what risk buckets they fell into, how many are engaged, how many have our nurses helped. And this might have been losing 10 pounds. It might have been, as a diabetic, going to all my preventive screenings for a 1-year period. It's any number of different things that could have occurred with these members. So this is how many we've closed, and then most importantly, how many people aren't picking up the phone. As Keith alluded to, when you've got the information, if something's not working, let's try plan B, plan C. The point is you've got the feedback here. Now, what's stage 2 of our risk management? When I was talking about these high and medium risk members, that's 21% of your population, and arguably the ones that are driving most of your risk. But what do we do about everyone else? Because this is a lot of people, and their claim projection is very low. So it is important that we address those people, but how do we do it? So this is benchmarking through Johns Hopkins. When I double click on this dashboard, again, you'll get a larger view, which I'll then maximize. So now take every major diagnosis category that really there is. I think there's 16 of them here. We show you how many members have incurred a claim within each of those categories. We normalize that number to a per 1,000. So in this case, you have 35 total members, but per 1,000, that represents 7.8. Then we show you Johns Hopkins. Hopkins is suggesting you should only have 5. So I'm going to focus on one category here, cardiovascular. Johns Hopkins is telling me when I open this, and again, this is on your desktop as an employer. So a couple of clicks, you're right here. John, with 99% certainty, I can tell you that your group's 36% higher than the national average in cardiovascular. That in and of itself is very insightful. But we've gone a step further and said, let's drill down. So now this company, again, with 100% certainty, knows that their incidence of high cholesterol is 58% higher. Blood pressure, 31%. Congestive heart failure, 70% higher. You can do this in every single claim category. Diabetics, 50% higher, 40% with insulin. Psychosocial, this is where we start to talk about stress-related issues. Anxiety, addiction, ADD, this is affecting productivity. So stage 2 of our risk management is helping you identify your specific company's risk footprint. No two companies are the same, and as such, no two wellness programs ought to be the same. So when we're talking about designing programs for your entire population, first you need to identify what my people are suffering from. And from there, you can start to design the right incentive programs, and then collaborate again with WellNet, with MF Irvine, to lean on us for our best practices. What's Penske doing for the automotive dealers? What's Burpee doing? What's A2E Pile doing for the transportation type of companies? So we've certainly got our best practices, and with the data, that's sort of how we start to move forward with all of our recommendations. So these were the real cool things that I love. Again, if you're just looking about getting your hands on normal data like medical claims, pharmacy claims, we've got all of that here. We've got some simulators that allow you to simulate generic use, what you'll save in a 12-month period. So there's a lot of great functionality on this site. I'll reiterate, this is your site as the decision maker, and it's the same site that MF Irvine shares with you. Now there's two other things I'd like to show you real quick, and that's what your member sees. So every member on a WellNet plan sees all of their drug data in real time. They can look at what generics are, what it is, why it's a generic, what they can save, what you can save if they make a better decision. All their medical claims in real time, all sortable, all their lab data. And arguably the most important thing we're doing is social networking. We call this My Wall because it's just like Facebook. When our nurse identifies a member that needs outreach and we engage that member, we try to get the member not only engaged telephonically, but also electronically. So if that member doesn't want to speak on the phone, as an example, we're always on the phone. So the last thing I want to do at 7 o'clock at night is talk to a nurse. But at WellNet, we've got to speak with nurses. That's part of our program. We walk the walk. And I'd prefer to communicate with my nurse either through my mobile phone or through my iPad. So I use the social networking feature. So the last thing I'll show you is our nurse portal. And this will be very high level. But my nurse, before she calls me, looks me up in the system. She can see every conversation she ever had with me. This is sample data. She can see my predicted risk through Johns Hopkins. If I have any medical conditions, they're all listed right here. All my pharmacies listed right there. Any gaps in care, patient alerts. If I've not filled a medication, if I've not seen my preventive screenings, it shows the nurse all of this in real time and lets her provide the right care at the right time, as Keith alluded to. All of the medical claims I've ever incurred. All of my pharmacy claims, the same view I had as a member. My lab data. My health risk assessments, if we're performing those for you, all the way down to my plan information, all the way down to the plan documents. So when we're consulting with members about missed meds or about upcoming preventive visits or specialist visits, we can talk to them about their specific plan and what providers are in network, what providers have the highest quality outcomes for procedures at the lowest possible cost. It's about using technology, as Keith talked about in Euro Motor Cars, to understand your plan and then to take action and measure it and manage it all in real time. So that's in essence the technology. I mean, we can spend one-offs with each one of you here and spend hours doing this, but it's pretty cool stuff, as you can see. And this information is very useful in terms of understanding and reducing costs.
Thank you, John. So what John had gone through was the technology that we've been using the past 4 years to save many of our companies a significant amount of dollars. I'm going to walk through 2 case studies in just a moment, but what the case studies will show, and as a result of the technology, is the engagement rates with those that are driving your cost on average, and this is without incentives, is about 45%. This is about 9 times higher, again, 9 times higher than what the carriers are doing or separate disease management wellness companies are doing, because we're getting to the right people at the right time, at the right place. And if you think about it, healthcare, it's not just about providing the benefit, it's a shared responsibility. You know, most employees, they think, you know, my company's paying for it, I can use it as much as I want, I can go get as many tests as I want. At the end of the day, if they continue to do that, and you as the owner of the company, the CFO or HR, ultimately, as you know, Michael had shared before, if you cannot continue to afford it, you're going to shift more costs. So it's about teaching the members that they too have a responsibility in educating themselves, in engaging, but you can only do that first and foremost as the plan sponsor, you having the data. Next slide. So this is an example. Viking Range out of Greenwood, Mississippi. You may have seen them in the magazines or on the main line. There's a beautiful cooking school and store. Viking Range, a couple of years ago before we got started with them, they had more in healthcare costs than they did in profit. We took their plan over, we identified the unhealthy members, and it was a little over 330 or so that were going to drive about $3.3 million in cost. What we did is we wound up engaging first year 45% of the members, and this year 63% of the members to save over $1 million in their healthcare plan. Two things attributed to that. A, they had their data, but B, the CEO, Fred Carl, he got intimately involved in the plan. It was the culture of the organization that allowed him to drive this kind of change and to let his employees know that it was important to him. Cumulus Media, which just bought Citadel this past year, they saved $500,000. $500,000 goes right down to the bottom line, to the shareholders, and very important for their company owner, Blackstone, T.H. Lee, and Bain Capital. These organizations, they drive process improvement on every aspect of their company with technology, but not in healthcare. That changed with us and with them. And so what you've been hearing about today are a little bit more for larger employees, let's call it 500, 5,000. What we've done is taken the same approach for these large companies and built a plan for those groups 50, 75, 100, 250 to have this same type of control, access, and understanding. So the best network, the best access, the best turnkey approach. So I see some heads in the room, you know, at times saying, oh gosh, that's a lot of data. I don't know if I want access to that. It's all turnkey. So Michael and his team, they have access to this. Our team of nurses, our team of advisors. As a smaller group, you may not want to have any of that information, but you want to know, where are my costs, where are my risks, what can I do about it, as John alluded to before, how many people are engaged. So by building a plan and taking the experience we've had in the larger group space down to the small group market in the Philadelphia and New Jersey space, we, along with Michael Irvine and his team, have now brought best of breed partners, best of breed technology, and the best small and mid-sized group health plan for an organization that really only had 2 or 3 carriers to choose from. And before I turn it over to the team, if you think about it, those carriers, they do a great job. But first and foremost, they're about protecting their profits. What WellNet and MF Irvine are about, you know, their history is all about giving as much money as you possibly can back to the client. Because the more money you save, and going back to that profitability chart, the more money goes back to the bottom line. And so the transparency is absolutely critical. This is the first time that a company has ever had the ability to finally have that grasp of all that information, all that interpreted data, all that access, and that understanding. Because if you can't get to the root of the problem, you can't fix the plan. Thank you.
Morning, everybody. I'm Paul Miller with MF Irvine. So what we've heard from WellNet is we've got this sophisticated technology to be able to identify your risks, what's driving your costs, and then engage the members through outreach and these programs. But what we heard from Mike Devine was that in the mid-sized market, in the fully insured market, there are things like credibility factors and benchmarking trends that are really hampering your ability to take full advantage of how much you can improve your overall costs. So what does an employer that doesn't have thousands of employees do? Well, there's a wide spectrum in terms of funding arrangements, financial arrangements that you can have to fund your employee benefit plan. On the one hand, you've got fully insured, where you've got set rates, and the only thing really that varies from month to month is the number of people that are covered under the plan. On the other end of the spectrum, you've got self-insured, where you're funding a bank account that will pay the claims as they're presented. But along the way, there are various different vehicles that may make sense in terms of a company assuming some level of risk to participate in the savings and the improvement of the overall claims experience. And our job is really in working with clients is to assess that level of risk that's going to provide the optimal results of taking advantage of that improved claims experience, but protecting your balance sheet in case of there's catastrophic claims, either on an individual basis or on an aggregate basis. According to the Department of Health and Human Services, a company that has between 100 and 500 employees is 4 times less likely to be self-insured. A company that has under 100 employees is 8 times less likely to be self-insured. And one of the main reasons is that in that size market, an employer may not be able to handle the volatility in claims experience. From month to month, you might have some catastrophic situations, and they may not be able to absorb that risk in terms of the impact to the bottom line. So what we would propose is that there is another way along the continuum of that fully insured to self-insured cycle. So actually, I do have the clip. So what you may have is, in any given year, for any employer, significant volatility in terms of what your claims experience can look like. There is an approach that may work well for mid-sized employers in terms of a flat monthly payment. And that flat monthly payment would be comprised of your maximum claim liability, stop loss to protect you against either adverse claims experience on an individual or an aggregate basis, and the administrative expenses that's going to be a part of the processing the claims in any given year. So what you can see that in positive months, any surpluses are going to fund future deficits or future shortfalls in the experience. Stop losses will be protecting you against any of those catastrophic risks. And at the end of the year, there'd be a reconciliation. And any surpluses would then go and be returned back to you. Now, it's a basic concept, and there are certainly some finer points, some more details in terms of it. But we're viewing this approach in terms of a level funding mechanism, coupled with really have an incentive and the tools to be able to improve the claims experience of your individual group, is something that's different than a lot of mid-sized employers, let's say between 75 and 500 employees, may not have been privy to before. Now, what does that allow you to achieve? What are the items that you may be able to eliminate from your overall costs? On the left-hand side, we've got $1 of fully insured premium. On the right side, we've got $1 of what would be an alternative risk financing method. Now, assuming that claims are going to be the claims, the employees aren't going to stop going to the doctor and start having any change in their conditions based upon what your funding mechanism is for both medical and for prescription drugs. Those are really going to be the same. But what you can, and in either plan, there's going to be administrative factors for processing claims, and you're also going to have insurance, whether it's stop loss or risk pooling in a fully insured arrangement. But what you can look at is things such as the profit, premium taxes, and more importantly, the underwriting factors, those credibility factors, those are the real things to glean out and to be able to carve away in years when you've got positive, favorable claims experience. So what we're suggesting is that, alluding to Mike Devine's earlier slide, is that there could be a better year in the life of the renewal process and in terms of managing your claims. So all these essentially controlling the data empowers you to have continuous data-driven plan management, to determine the conditions that can be impacted, to monitor results in conjunction with WellNet and share recommendations on either wellness campaigns or outreach or plan design changes that would be able to incent employees to be able to better improve the performance of the plan, and then work with you on an ongoing basis to assess your appetite for risk and use predictive modeling, as John had showed, to really not just take a guess at what should be happening next year, but really predict with a very high level of accuracy, what is that risk going to look like next year? And how can I plan for it and set the proper budget? So all this is in an effort to achieve sustainable improvement in your overall claims experience and to protect your bottom line for the short term and for the long term. So I think that this model, as well as deciding where you need to be in terms of the continuum of self-insured to fully insured, is something that's going to be key towards taking advantage and leveraging this type of technology. With that, I'd like to open it up to questions, if anybody's got about any of the items that we talked about today. Yes?
When you're talking self-insured, is this like a savings account type stuff, or how do you do that?
No, this essentially would be you funding a bank account. Instead of paying premium to a carrier, you would pay under that arrangement, and there's many different arrangements, again, along the continuum, where you could either just fund the bank account and then pay fees to process your claims. But under this model, where we're talking about a level funding, is you would pay a set amount each month. It would be encompassing your maximum claim liabilities, no matter what happens, that's what you're funding. And it would pay the administrative expenses, and it would fund a bank account. So this is irrespective of plan design. Plan design is a whole other discussion in terms of what's the optimal plan to give a plan that provides the most value, perceived value of the employees. But this is about how you are funding the actual plan, whether it's paying premium on a fully insured basis or funding a bank account that's going to be able to process claims.
And do you have insurance for the catastrophic type?
Yes, it's called stop-loss insurance, and that can be integrated into the flat monthly payment, or if you wanted to do outside of this flat monthly payment, you have stop-loss that would be on an individual basis to guard against a catastrophic situation with one member. Say there's a stroke or severe head injury or some of those things that do happen. Also on an aggregate basis to protect you from claims that are going to be over your expected level. Okay, so on an individual basis for those things that are very much unexpected, but also on an aggregate basis so that you can really set a budget if bad things happen. And with all the good efforts and technology, if things are just going in a different direction, you do have downside protection.
And you're mixing this together with the WellNet management as well.
Correct. I think that's the key, is that rather than just guessing what's going to happen next year, rather than just hoping for the best in terms of what the claims experience is going to be, take active steps as you would in managing any other aspect of your business to treat this as an expense. And the other thing that maybe that John and both Keith alluded to is we view that we are a very active participant in this, so that you don't have to be sitting by your dashboard every morning. You certainly could if you'd like, but you may have some other things to do, so that we would really be an active participant in working with WellNet to identify areas that are going to be able to have a positive impact on your plan.
If I could just add to that, that microphone is working. If you think about it, it's the same as a fully insured plan. It smells and it looks like that, so it's got the same pharmacy and medical benefits, the same technology that John had showed you, the population management, but it's got, as Paul had mentioned, the stop loss that is actually built in. And so when the plan runs, when there is savings, at the end of the year, those savings goes back to you. But what you have, aside from the savings, is all of that interpreted and actionable claim data. So just recently, I think it was about 2 years ago, we took over a group in this area, Cardiology Associates of West Reading, and the group was going to receive a 45% increase from their carrier. They said, absolutely not. Not only is that outrageous, but we can't afford it. They came to our program, the small group health plan, so they got the pharmacy, the medical, all the technology, everything we've described, and the plan ran so successful that at the end of the year, we cut them an $80,000 check. But now what they have is all their claim data, which we're now using this year to manage their plan down again. So hopefully save even more money. So again, same exact thing, same exact offering as you're fully insured. It's just a different funding mechanism. Let's say self-funded on training wheels.
Yes.
Privacy. I guess the question is, I'm a CEO of a company, and hearing what you laid out, it's exciting to be able to understand the health factors, hearing that you're getting 45%, the other 55%. What can a company, what information can I get of my 55% of my employees that aren't connecting with you? How do I do that? I mean, liability, all those wonderful things.
So you're saying specific information or aggregate information on the people that are not using the plan per se?
Specifically, I want to reach out and have 500 employees, whatever your statistic number is. I want to bluntly go to John and say, John, A, I care about you. I want you to live. B, I want to make sure the costs are being reduced. I mean, both of those factors are important. The company needs them, not at the hospital, not sick. I need them at work.
So there's a couple things. There are carrots and there are sticks. You can use incentives or you can use penalties. If you don't participate, with a care manager as an example, you're going to get docked $100 or $200. If you do participate, you may get $300 as an example. But in terms of privacy and you specifically having access to it, I would think that unless you're a privacy officer or somebody in the company is a privacy officer, you typically don't want access to that in terms of you and your organization. But our team of nurses acts in the same way that an Aetna, Cigna, United does, in that we know who those members are that are both being outreached to as well as not outreached to, and so we can do that on your behalf.
So you would be the carrier of the state.
That's exactly right.
So I'd say, hey, give $100 for everybody who's willing to do it, and then we reach out, and then obviously there'd be just a lump fund, and you'd be paying that.
That's exactly right. So I'll use an example of Cumulus Media that we showed before. Lou Dickey, he wanted the highest level of engagement. He's a Stanford, Harvard Business School guy. And he said, you know what, I want to set the standard in the industry, not just radio business, but all companies around the country. For anybody that participates with the care manager that's been identified as high or moderate risk, I want to give them 30% off their premium contribution on a monthly basis. That is almost unheard of. He has 80% engagement of his members, where typically what you're seeing from the carriers or disease management companies is 2, 3, 4, 5, maybe 9% at best. So, record engagement because the right incentives and also the right messaging. That's exactly right. Top down, as Michael said. Yes?
Actually, the unhealthy employees are unhealthy because they're not focused on health. So what techniques does your nursing staff use to engage them without feeling like you're infiltrating their privacy?
Great question. So what techniques do we use in terms of the ability to outreach to members without infiltrating the privacy? Well, if you've ever been into Nordstrom's or the Ritz-Carlton, they treat you almost like family. How can they help you? What can they do for you? Nice to see you again. It's not so much that we're outreaching and saying, we understand you have cardiovascular disease combined with, a diabetic issue. It's, I understand you may not be feeling well. How can we help you? And we begin a dialogue that is more engagement, more sensitive to the member and getting to know them. And once that member creates a dialogue with that nurse, it is always that same nurse that they're actually dealing with. Relationship.
Is this available in captive?
It is. We certainly do have some groups that are in a captive arrangement and can provide that in conjunction with MF Irvine. Absolutely.
Yeah, that's a great question in terms of that is one of those vehicles along the spectrum where if someone doesn't feel comfortable with their own isolated risk of their plan and the volatility of having your own experience, even with the protection of the stop loss that we mentioned before, a captive is arrangement where you're kind of operating an insurance company where a number of companies are pooling their own claims experience together. So diversifying a little bit, if you will, to achieve an overall. Now you won't realize the gains in the best company that is having the best performing experience wouldn't realize the full gains because they're pooled. However, they could mitigate some of their downside by sharing some of their claims experience and spreading some of the risk. So it's groups getting together that are kind of in a similar arrangement of self-insuring their plans.
Typical captive structure too, everyone's a member.
Yes.
Right.
Yes.
Yes.
Yes, I'm CFO. I'm involved with an association. We have employers from 100 to 20,000 employees, so I hear these issues all day long and searching for solutions. I was introduced to WellNet, I guess, about 5 years ago, so I applaud the company. It really has driven terrific technology. One thing I didn't hear, and maybe it's part of the model, is when we're looking at employee populations, claims data is really important. And I'm glad that's part of it, and RX is a key component. But how about those employees that we look at as ticking time bombs? The ones that, A, either don't know that he or she is a health risk, so they're not going to show up in claims, or secondly, they know they're a health risk, but they're not being compliant, so they may not be showing up in the health risk. We try to get at that with maybe biometric screenings or some other type of methodology to try and capture those folks in a net. Does the model include that data as well?
So Bill, first and foremost, thank you for the compliment. Our team has worked very hard to, I'd say, build solutions that are common sense and understandable by CFOs. The second part of your question is yes, the modeler and the way that we've designed the technology is it's in essence, an open API. So we can take any type of data set, medical, pharmacy, lab, biometric, you name it, and add it to the modeler, identify gaps in care. So as much or as little information as we can actually get our hands on, absolutely.
And also, as we're identifying these risks, or maybe there's some people that we aren't getting to, there may be other programs that we bring in piecemeal to apply to the overall concept in terms of how we're going to get at this. So we want to leverage the great technology, use different funding mechanisms, but there may be some people that are tremendous on a local level of being on site, nurse practitioners to do those biometric screenings, or we might define what is the best health risk assessment to utilize, making sure that we're using that, providing that data to WellNet to leverage their resources for outreach, but we may plug in different resources to be able to solve the problem.
If you think about it, just to add, the thing is that no two groups, even if you're in the same industry and same demographic, no two groups essentially are the same because they have different eligibilities, different makeups. They're spread out over the country. While you may be headquartered here in Philadelphia, you may have divisions out in California or in Georgia, and each one of those eligibility files run differently, utilize the health plan differently. And so you've got to be able to take that interpreted data, not just on an aggregate basis, but on a segmented basis to develop the right kind of campaigns and outreach to get to those people that are using, or shall we say, misusing the plan inappropriately, to get them smarter and to teach them. And you can only do that if you have that information. So it's the right time, the right plan, but being able to segment that information because, again, no two plans essentially, while everybody, there's men and women in here, everybody's very unique, and that's the same thing with the health plans. I mean, Michael and I, we talk about that all the time. And so it's that customized solution that gives you the kind of control and understanding to determine what to do, when to do it, and how to do it on a continuous basis. Thank you, Bill. Yes?
How do you fix the prices with the doctors and the hospitals?
Well, we're working on that right now. I mean, I think you see some of the organizations right now, hospitals specifically, developing into what's called an ACO model, where they're incentivized differently, these primary care medical home models. We're going to see what happens after November 8th, or November 6th, excuse me.
No, I mean, a self-funded plan.
Yeah.
How do you pay the claims? How do you have a fix on the prices?
Oh.
There's a network in place. A couple different networks to choose from, but there's a network that's in place that has negotiated those discounts. And then processing the claims, there's a claims processor, a third-party administrator that actually will adjudicate all the claims. So it's a component of this overall strategy, is to have stop-loss protection, a claims administrator that adjudicates the claims, a network so that people will get those preferred pricing, those discounts to pay retail as opposed to, or wholesale as opposed to retail, and then do all the reporting capabilities that John had talked about.
So to drill down a little bit further, as the example, the TPA that we partner with is Meritain. Meritain happens to be owned by Aetna. They came to us because they recognized the technology. And so they said, listen, we know that other TPAs around the country, other third-party claims payers around the country have access to the Aetna network. But because of your technology, we're going to give you a better discount than what the traditional administrator gets. So WellNet has what's called the CP2 discount network in this region, which is parity pricing with what Aetna makes available directly to their customers. So we finally have parity with the large carriers, where traditionally before, years ago, we couldn't compete. So we've just, over the past 24 months, brought in Cigna, but in this region, Aetna, to create that level playing field for our customers. So again, through the TPA, sir. Yes?
The employee walks in with a card from
That-
Barrett or whoever.
That's exactly right. So the employees walk in with a card, it could say WellNet on it, and it's accessible via the Aetna network, via CVS Caremark pharmacies, and it could even have your company's logo on the card that's utilized just like a United Healthcare card or a Blue Cross card. Yes? Yes, sir.
Have you considered trying to tie in workers' comp losses, or if you have data to show you can drive employees to be healthier and workers' comp claims go down as well?
We're actually working on that right now, and realistically we'll have something along those lines in the second quarter of 2013, but that's next up on the agenda for us. Yes?
Does that network with pricing across the country, or might be regional?
Absolutely.
From every state?
Across the country.
Great. If there's no further questions, I'd like to bring up Pepper Crash, partner with MF Irvine.
Well, we want to thank you all for attending this morning. I have the distinct pleasure of closing our session this morning. On each of your tables, there is an evaluation form. We ask that if you would please take a minute to complete them. This seminar this morning is the first in many that we will be presenting as we move forward. So if you could help us with some additional ideas, we do have a calendar and some different topics that we'll be presenting as we move forward into 2013, but your input would be very helpful. The next session that we'll have will be a webinar on healthcare reform, and that you'll see that toward the end of 2012 or the first quarter of 2013. You might have noticed that we're recording the session this morning. Snippets of this session will be on our website, www.mfirvine.com. And so for those of you who need to refer back or would like information about this morning's session, you will be able to retrieve that from our website. On behalf of my partners, Michael Irvine, John Ziegler, myself, and all of us at MF Irvine who's here today, and in fact, I'll ask all of you who are with MF Irvine, our employees that are here, if you could please stand up for recognition. From all of us, thank you so much for taking time out of your day to spend this time with us and learn a little bit about healthcare. I have the distinct pleasure of announcing the winners of the Eagles football tickets, and we will get these tickets to you. Susan Lippert, Security Resources, and Paul Straub for Fox Rothschild. Okay, thank you very much.